If you are ready, I'm gonna introduce you, and so you can give us the opening
好的，那欢迎同
remarks.
事请翻到
Okay.
许教授的介绍那一页。好，
Okay.
那各位专家晚上好，
Respected
我是感染
experts,
线的
good
张梦。
evening.
那非
My
常
name
感
is
谢各
Jia
位
Meng.
专家
I'm
能
from
以
the
今天参与
Infect
到我们本
this
次
role.
MDT 联合会里
Welcome
面
to
来。那
Intensive
首先
Infectious
邀请
International
徐斌教授
Multidisciplinary
来
Consultation
为
Training
我们
Program.
做第一场第一
Firstly,
部
I'd
分的
like
主
to
持。那
invite
徐斌教授
Professor
是
Xu
中南大学
Ping
传
to
染第
give
二
us
院
the
的
opening
专
remarks,
家。
and she
那
will be the moderator of the
首
first
先邀
session.
请徐教授，
Professor Xu is
徐
from
教授
Second
请
Shanghai
您
Hospital
主持我们
of
今天的
Central
MDT。
South University. So, Professor
好
Xu,
的，
over to you.
尊敬的这个罗主任，还有我
Respected
们
Professor Luo,
方教授两位主席，
Professor
以及来
Huang,
自意大利的
and
这
also
个 Carlo 教授和
the
Sam 教授，
Professor
各位专
Carlo
家，
and
各位
Professor Simon
同道大
from
家
Italy.
晚上好，很高
Respected
兴很荣
experts,
幸
good
有
evening.
这个机会
It's
参
my
与
great
今天
honor
晚上的
and
这样一
pleasure
个重症
to
感染和寄
attend
多学科的这样的
intensive
一个
infectious
联合会诊的这个项
infections
目。那
international
么首先呢，
multidisciplinary
就有请
consultation
我们
training
今天
program.
的两
So
位大会
firstly,
主席
I'd like
的
to
致
give
辞。
the
首先
floor
是
to
有
the
请我们
two
的罗
chairpersons
红
to
教授。
give us the
罗红
opening
教授
remarks.
是
The
我先
first
简单的介绍一
chairperson
下
is
罗教授。
Professor Luo
罗
Hong.
教授是我
So
们中南大
Professor
学
Luo
沙雅二
Hong
医院的
is from
呼
Second
吸
Shanghai
微
Hospital
生物
of
学科
Central
的
South
主
University.
任。
She
我是
is
亚专
the
科的
chief
主任，也是
physician,
教授，
grade
一级主任
one
医师和
professor,
博士导师。
doctor
同时也
supervisor,
担任着
and
中华
she
医学会
is
呼吸病学
also
会呼
member
吸
of the
微生物学
respiratory
组的
critical
委
care
员
group
和
of
中国医
respiratory
师协会
disease
呼
branch
吸
of
医师
Chinese
分会
Medical
的委员，
Association,
以及中国医
member
师
of the
协会
Internal
呼吸医
Medicine
师分会
Physicians
微
Branch
重
Chinese
症医
Medical
学工作委员会
Doctor
副主任。
Association,
也还担任着我们中
and
华医学
she
会呼吸
is
病学会
also
分会呼吸异
member
常
of
与
the
罕见
Respiratory
病
Physicians Branch
这
Chinese
个
Medical
筹备
Doctor
学组的副组
Association,
长等等，还有我
Deputy
们湖南
Director
省
of
医师
the
协会
Critical
呼
Care
吸医师分会的
Medicine
会长
Working
等
Group
等很多
Respiratory
的
Physician
学历头
Branch,
衔，
and Vice
也主持
Chairperson of
了
the
国家治安科
Respiratory
委基金的
Genetics and
面
Rare
上项
Disease
目4项，
preparatory group. She is also standing committee member and deputy director of the ICU pulmonary rehabilitation group. She also has many other academic titles and awards. Thank you, Professor Xu, for your kind introduction. Distinguished experts, my name is Luo Hong. I'm from the Second Shanghai Hospital, Central South University. It's my great pleasure and honor to be with all of you at today's meeting, and this is the third online session of this program. Actually, we know that for the resistant gram-positive infection is also a global threat and causing huge burden to the whole health system. So with today's program, with the international exchanges, we can have then we can have a better understanding of the diagnosis and treatment of the resistant bacterial infections. And with that, we can make our contributions to the advancement of the treatment of the resistant bacterial infection. I necessarily hope that we can generate many insights from today's meeting. I also want to wish this meeting a great success. Thank you, Professor Luo, for your kind opening remarks. So now I'd like to invite Professor Fang Wei from the Shandong Provincial Hospital to give us the opening remarks. He is chief physician, doctor candidate, postdoctoral supervisor, and he is the director of the Department of Critical Care Medicine of Shandong Provincial Hospital, member of the National Health Commission's Medical Emergency Response Expert Group, member of the National Critical Care Medicine Professional Medical Quality Control Center, member of the Critical Care Medicine Branch of Chinese Medical Association. Over to you, Professor Fang. Distinguished experts from the infection field, respected Professor Luo, and respected chairpersons. My name is Fang Wei. I'm from the Critical Care Department of the Shandong Provincial Hospital. It's my great honor to attend today's training program of the MDT of the infections. And I think nowadays for the community-acquired resistant bacterial infection, it is indeed a very tricky issue for the whole health system. And so we are actually having the great mission to overcome the related resistant bacterial infections. And I think for today's meeting, with combined wisdom, and we can make further contributions to the prevention and treatment of the resistant bacterial infection. And I sincerely hope that you can have the active participation and sharing insights with us. I also wish today's meeting a great success. Thank you. Thank you, Professor Fang, for your kind opening remarks. Without further ado, we will enter into the first academic session. So the first talk will be given by Professor Qu Jian from Second Shanghai Hospital, Central South University. So today, Professor Qu Jian will share with us the diagnosis and treatment of gram-positive bacterial infections, clinical application of the new generation cephalosporins. Professor Qu is the deputy researcher of the pharmacy department. He is also the doctor supervisor, and he is also the pharmacy doctor under the co-training program between Shanghai and Harvard. He is also a member of the Precision Medicine Branch, Chinese Society of Cardiovascular and Thoracic Anesthesia, member of the Precision Pharmacy Service Committee of Hunan Pharmacist Association. And actually, in terms of the clinical practices, the training as well as researches, he has a lot of achievements. And also, he published more than 90 SCI papers with high recognition. He has a lot of scientific achievements, and he has presided over 9 projects funded by National Natural Science Foundation and participated in multiple projects, including National 863 program. So over to you, Professor Chu. Thank you very much for your kind introduction. Respected Professor Xu, Professor Jiang, and the 2 distinguished Italian professors, it's my great honor and a pleasure to share with you the topic about infection. So I'm going to share my screen. Bear with me for just 1 minute. Okay, so the topic for my talk is diagnosis and treatment of gram-positive bacterial infection and clinical application of the new generation cephalosporins. My talk is divided into 3 main parts. The first one is the current status diagnosis and treatment positive bacterial infection. We see a lot of treatments about the gram-positive infection. However, nowadays, for gram-positive infection, we have the Staphylococcus aureus, and actual distribution is also around 8%. And actually, for the Streptococcus as well as the Staphylococcus facialis, and actually we would also encounter those gram-positive infection, and actually from MRSA as well as the vancomycin applications, and actually according to genetic study, actually the MRSA sensitivity from the 2003 to 2004, actually we see the increased proportion, and actually has increased from 20.8% to around 30%. So for resistant gram-positive bacteria, it has a certain proportion, especially when it comes in the ICU patients. And actually, for the treatment, we need to have the gold triangle, and namely the pathogen in the patient situation as well as the resistance situation for the severe infection. And actually, we need to be precise, and we also need to have the potent drugs for patients of different age groups, of different weights. We should choose different drugs. And also for the genes that have impacts upon the drug metabolism, we should also pay attention to that. We also need to follow upon patients' kidney function and other liver functions to make the right medicine choice, especially when we utilize the vancomycin. And also we need to understand the coagulation, the triage situations of the patient, and also the basic disease as well as the immune status of the patients would also have impacts upon the medicine choices. In terms of the pathogen studies, I understand nowadays we have the PMS and as well as other testing methods. We have quicker understanding of the pathogens of the patients. Actually, we will shorten the period between empirical treatment to the precise treatment. We also have combined the stability test, and also we combined drugs. Maybe it can work better for the patients. And I also need to confirm what is the source of the infection as well as the severity of the infection. And then we can have the best choice of the right medicine. At the same time, we also need to have full understanding of the medicine-resistant bacteria, and also for PKPD as well as the tissue distribution. We need to have full understanding of them, and on different tissues, they have different penetration potency. And also in the local infection situation, we need to choose high concentration drug. We also need to pay attention to safety and efficacy issue, and then we will finalize the dosage choice, and then we would pay also the attention to the PMT as well as the pharmacoeconomics. But the ultimate goal is the 5R at the right patient, the right time, to use the right drug with the right dose for the right usage. So that's the 5R principle.
So that we can have a more precise treatment to improve both the safety and the efficacy of our patients. For gram-positive infection, what drugs can we choose from, especially for the resistant gram-positive pathogens? We have some agents that we can choose from. The first one is vancomycin. It has a well-established evidence for resistance per se. It is relatively rare, like the Enterococcus faecium and faecalis. Not all of them, not a lot of them are resistant. And also it is a bactericide. It has a very high potency in killing bacteria. It has its own cons. The first one is renal toxicity and ear toxicity, and also red man syndrome. If we give the IV administration too fast, it will lead to red man syndrome. TDM need to be conducted to make sure about the trough concentration. AUC is used commonly to see whether it's within the rational range of dose. It has a wide application for bloodstream infection. It is a first-line treatment. The second one is teicoplanin. It has a relatively small renal toxicity, but we need to conduct the TDM. But the disadvantage is that it's relatively slow in terms of efficacy onset. It changed the user manufacturing booklet, but we needed to have complex and complicated dose. We need to have a first 3 dose as a loading dose, after which we can titrate to maintenance 1. And the adverse events, there was no real-world study to explore the side effects. It is recommended as a second-line treatment. The third one is a linezolid. It has a high tissue concentration because its molecule weight is small. For those with a renal or hepatic insufficiency, we don't need to change the dose, and it has oral sequential therapy. But the disadvantage is that the blood concentration is relatively low and not stable. So for the resistant positive infection in the bloodstream, we cannot choose elazolid, and it will lead to thrombocytopenia and the reduction of other blood cell. It will have a bone marrow suppression and other adverse events. We need to do TDM. It's recommended as a second-line treatment. For lung, it has a high concentration, so it can be recommended. Also, it has a good penetration across the blood-brain barrier. It can also be used with other drugs, including antibacterial drugs. For daptomycin, it has a fast onset of efficacy. It will have a role to play in the agents in the pathogen that are active in the static phase. But in the lung, for the lung infection, it is ineffective. So the evidence needs more accumulation, and it also has a target on the biofilm as well. So the first indication is a bloodstream infection, patients that are contraindicated for vancomycin, and also daptomycin is suitable in the second line for those with endocarditis. And for those with both gram-positive and negative infection, we can use tetracycline because it has a high concentration in abdominal cavity, a low concentration in bloodstream, and it has a relatively broad antibacterial spectrum. It has a natural resistance to PA or Pseudomonas aeruginosa, and it has a relatively low lung tissue concentration and low in bloodstream, and it may lead to many adverse events. And relatively speaking, in our clinical practice, the renal toxicity and hepatic toxicity. That's why we use tetracycline in those with abdominal cavity infection and soft tissue or soft skin infection. We see a lot of study focusing on vancomycin-caused acute kidney injury, where TDM monitoring is needed to make sure the concentration is within a rational range between 10 and 15. Below 10, it will lead to resistance. Over 20, maybe it will increase the risk of renal toxicity. That's why while using vancomycin, we need to strike a balance between efficacy and renal safety to adjust the dose. And for a lot of etiology, maybe it will impact the blood concentration, like those with hypoproteinemia, it will reduce the concentration of mycomycin. So those with hyperfunction and hypoproteinemia, the reach target rates relatively low in this subgroup of patients. Secondly, for the nasal lead, it will lead to thrombocytopenia, anemia, and other adverse reactions that are reflected by a lot of real-world study. 10.7% of the patients will occur anemia, especially when they use linezolid for a long time, 11 days minus or plus 6 days, it will lead to anemia. Of course, for the gram-positive bacteria, we have novel drugs. This is this cephalosporin already on the market, but the indication in China is HAP, HAP, and CAP, CAP. For HAP or HAP does not include VAP or ventilator-associated pneumonia. The reason lies in that when we are conducting phase 3 clinical trial and a real-world study, the study have not show great efficacy in those with VAP. According to US FDA, as we can see from the slide, including adults and pediatric endocarditis and skin and soft tissue infection, and also for pneumonia, indicated for both adult patients and pediatric patients, the same as EMA in Europe. Also, the pediatric and adult CAP and HAP, it is a 500 milligram per vial. So we will use a 5 milligram every 8 hours. We need to be mindful that every time we need to make sure at least 2 hours of infusion. That's the administration requirement for cephalosporin. According to the MOA of cephalosporin, a lot of beta-lactam, it will increase the cell membrane wall synthesis. It will combine with the PBPS to inhibit its activity so that the cell can be degraded. For the resistant mechanism of Staphylococcus aureus, the reason lies in a PBP2 protein that leads to methylene resistance. We know the cephalosporin, its action mechanism of action lies in its binding to PBP2A, inhibiting the protein action. So for E. coli, we can also see the inhibition targets are PBP2 and PBP3. So that's why cephalosporin, like ceftriaxone, it can inhibit the PBP2 and PBP3. That's why they show very good potency to E. coli. For PA or Pseudomonas aeruginosa, it has very complex resistance mechanism. However, PBP3 is an important binding site that leads to cell death. Our Ceftera or cephalosporin can combine with the PBP3 so that it can inhibit PA. But on the other hand, the ceftriaxone, it doesn't combine with the PBP3. That's why it is ineffective to PA. That's the target and MOA of this drug. For in vitro study and a lot of susceptibility tests, of course, in the Europe, Turkey, and Israel study, among gram-positive one, including SA, including the sensitive one and resistant one, and MRSA, MRSA, and also the CONS, and also the Enterococcus faecalis. It has a high sensitivity, 90% or more in accessibility. For gram-negative one, we have seen a very good results for enterobacteriasis and also non-ESBL producing ones. It shows very high accessibility. But for those ESBL producing ones, these cephalosporins cannot cover them currently. According to the foreign in vitro study, it shows a very good result. What about China? As we can see, show from this slide, the data are consistent in vitro activity of cephalosporin in China, including the resistant gram-positive and also non-ESBL producing the gram-negative ones. It shows a very high accessibility. According to those gram-positive pathogens that are resistant to vancomycin and daptomycin, and also Visa, H. Visa, and VRSA, cephalosporin show very high susceptibility and activity. According to this table, it showed 100%. So for those who are resistant to linezolid and daptomycin, we can consider using cephalosporin for these patients. For generation 1 to generation 5 cephalosporin, and we can see the beta lactamase stability. The gram-negative for the 5th generation, it has the highest potency. But for gram-negative pathogen, for those non-ESBL producing ones, it showed a very high efficacy, especially for PA. It shows a very good activity for this pathogen. According to PK/PD of cephalosporin, after one dose in the serum, cephalosporin it achieved the peak concentration after infusion, 30.2 milligram per liter. That's the average Cmax, very high. It is metabolized through kidney, more than 90%. So different renal function will have a role to play for the concentration. We need to adjust the dose accordingly. The half-life is 3.52 hours. It will have not a very great impact on the kidney. The hypoproteinemia patients will not be influenced a lot accordingly. The bloodstream concentration is high. In the bone tissue, it's at least one half or one third of that of blood concentration. In lung, 26%, CSF 15%, and bone fat higher. The skeletal muscle 69% and fat 49%. Additionally, the administration requirement, it can achieve very high target rates according to common administration, 500 milligram Q8 hour for 2 hours, treating infections caused by Streptococcus pneumonias, Staphylococcus aureus, and non-ESBL producing antibacterial. It can show very good efficacy. So is the same efficacy was observed in treating PA. So are there any treatment modalities impacting its efficacy? Of course, ECMO for starters. But according to the experiment, compared with those without ECMO, those with ECMO does not affect the PK/PD significantly. There are other studies in other countries conducted in a real-world setting showing cephalosporin effectively treats HAP and reduces 30-day all-cause mortality. Subgroup analysis also showed that for the elderly patients with multiple comorbidities, including bacteremia and COPD, cephalosporin is superior than ceftazidime and linezolid. For HAP or HAP patients, it shows very early improvements. As early as 4 days, it can already improve the patient's symptoms, including those compared with ceftazidime and linezolid. For the SA and MRSA, it showed very early efficacy.
And also for CAP patients, especially the elderly CAP patients, for patients about 75 years old, the clinical cure rate is of the cephalosporin is better than the cefotaxime in combination with the linezolid. In addition to that, for the onset speed, we can see cephalosporin is also very quick. And also for 30 days mortality rate for the cephalosporin with or without the linezolid compared with the cephalosporin is also superior. And also for the complex Staphylococcus aureus infection patients, we found that for the median time to MMSA eradication is only 3 days. Therefore, for the complicated Staphylococcus aureus bacteremia, it is not inferior to the datamycin with or without the cephalosporin. And also for the soft tissue infection, and if we compare against the vancomycin with the aztreonam, and here we can see this is the phase 3 randomized double-blinded trial, and actually in terms of the early mitigation, patients cephalosporin is better than the control arm, and also for the MMSA infected patients, the mycobacterial response of the cephalosporin is higher, meaning that it has higher eradication rate for the microbiomes. And also for CNS penetration as well as the CFS penetration rate, we also identified a higher concentration of the cephalosporin. And also for the virtual biofilm killing efficacy of the cephalosporin, and in this study we found that for some gram-positive bacteria, when they have the implants, for example, like the valve as well as the coronary stents, etc., they are very likely to have the biofilms. And actually, for the cephalosporin, it is able to inhibit the formulation of the staphylococcus biofilms, and for gram-positive bacteria, cephalosporin is superior than vancomycin, datamycin, and rifampicin. And also in terms of pediatric patients treatment, cephalosporin is also very effective in EU-approved indication. It also includes pediatric HAP infection. In 2 studies, they proved that tolerability of cephalosporin is better, and we know that for beta-lactam, they have higher intolerability issues. Therefore, for cephalosporin in treatment of the gram-positive bacterial infection, when it is compared against the datamycin, vancomycin, and linezolid, it is able to have quicker onset of the rapid bactericidal effects, and also it is better in terms of the biofilm inhibition, and has wide indications, including the elderly patients, pediatric patients, as well as the endocarditis patients. According to China's guideline, in the 3rd version of the microbiome treatment, they stated that for the HAP patients that have the risk for MDR infection, as well as the empirically treated CAP patients, we can utilize the cephalosporin. And also here you can see for pediatric pharmacists, the consultation dictionary as well, infectious disease and microbiome therapy 4th version, we have the statements to recommend cephalosporin. And also in the foreign guidelines, you can see for CAP of adults and children, we also see the recommendation of the cephalosporin. So for the international guidelines, they recommend cephalosporin in combination to do salvage treatment, especially when patients fail the vancomycin or daptomycin. We can also combine cephalosporin with vancomycin or the daptomycin to salvage those patients with the complicated Staphylococcus aureus infection. So in conclusion, we can say that cephalosporin is highly potent for gram-positive infection as well as the negative Staphylococcus, the non-ESBL producing E. coli, non-ESBL producing Klebsiella pneumonia, etc. They can work very well. It has very quick onset speed. Median clearance time is only 3 to 5 days, and with very good early improvement. Another important feature is the good safety profile. It has no nephrotoxicity nor thrombocytopenia. The TDM monitoring is not required with wide adapted population. And so I understand if we're able to have the blood concentration detection, maybe we can offer the more precise treatment. And also sometimes when we see very complicated cases, we can have the cephalosporin in combination with cephalosporin with the linezolid, etc. With that, we can have quicker eradication of bacteria. And the recommended dosage is the 500 milligram dose Q8 hours, administered intravenously for 2 hours each time for 7 to 14 days. And actually, for the patients that have the hyperkidney function, we may need to increase the dosage, and also for the liver function part. Normally, it has no liver injury, therefore, normally we don't need to adjust the dosage there. For the gram-positive bacteria as well as the non-ESER producing E. coli, it is indeed a very good choice to treat those patients. Thank you for your kind introduction. I think within such a short period of time, he actually briefed us on the highlights of the drugs for the treatment of the gram-positive infection. And he touched upon the cephalosporin, which is the 5th generation of the cephalosporin. And also we compare that against the currently available drugs. He touched upon PK/PD of cephalosporin, and he made a lot of comparisons between different drugs, especially nowadays in clinical practices for gram-positive bacteria and the resistant bacteria-induced CAP, as well as the intracranial infection. It may also work. And in the special population in elderly and pediatric patients and the patients with the compromised kidney and liver functions, we can also utilize cephalosporin. And currently speaking, we are still kind of new to this drug. We didn't have much experience. I think when we utilize cephalosporin, because more than 91% will be metabolized through kidney. So for the renal function compromised patients, we may need to be a little bit more cautious. However, it has very quick onset of the efficacy for adults and pediatric patients. So I think through his talk, we actually have high expectation for this drug. So I think later we're gonna have the panel discussion. So I will stop here. Thank you, Professor Chu, again for your wonderful presentation. Okay, now I will hand over to Professor Jiang Zhiming from First Affiliate Hospital, Shandong First Medical University. I'll introduce Professor Jiang shortly. Professor Jiang is the director of the Department of Critical Care Medicine of the Shandong First Medical University Affiliate Hospital. He is Chief Physician Medical Doctor. He's member of the Oncology Critical Care Professional Committee of Chinese Anti-Cancer Association, Director of the Critical Care Medicine Professional Committee, Shandong Health Information and Health Medical Big Data Society, Vice Chairman of Critical Care Medicine Branch of Shandong Medical Association and the Parental and Enteral Nutrition Branch of Shandong Medical Association, and it has many other important academic titles. For the interest of the time, I will not read all of them. Over to you, Professor Jiang. Thank you, Professor Xu, for your kind introduction. Respected chairpersons, respected guests, and our dear Italian professors. It's my great honor and pleasure to attend today's online international meeting. So and I'm going to moderate the second session. In this session, firstly, we have Professor Simon Giuliano from University of Udine Medical School to share with us the HAP mindset. So I'm going to introduce Professor Simon. He is from the University of Udine Medical School, and he is the resident in infectious disease at Department of Public Health and Infectious Disease, Policlinico Uberto, University of Rome, Italy, and he is responsible for chronic hepatitis C, chronic hepatitis B, and HIV in patients' care in outpatients. And he is also consultant of the infectious disease in medical surgical intensive care unit. He is also ICU observer at the Royal Bristol Hospital of Anesthesiology and Critical Care. So over to you, Professor Simon.
Thank you very much. Just a sec, I shared the slides. Can you see them?
Yes, I can see.
Okay. So thank you very much for the invitation. I'm going to present today a case of hospital-acquired pneumonia due to methicillin-resistant Staph aureus. The past medical history of this patient was remarkable for psoriatic arthritis on immunosuppressive therapy with upadacitinib, that is a Janus 1 kinase inhibitor, and corticosteroid. The association of this upadacitinib and corticosteroid is associated with infectious disease complication in patients who administer for whom these two kind of drugs are administered. In 2010, the patient underwent sigmoid colectomy for colonic cancer. He presented at the emergency department on September 2024 because of fever and altered mentation, and a clinical picture that resembled tonic-clonic seizure. An electroencephalogram showed abnormal electrical activity at the left temporal and frontobasal region, and magnetic resonance imaging showed the presence of mild hyperintensity in the limbic cortex. These are two scans image in diffusion-weighted and T2 flare. The patient immediately underwent a lumbar puncture for examination of cerebrospinal fluid. Cerebrospinal fluid appear colorless with normal glucose and normal CSF to serum glucose ratio. It showed high protein, mildly elevated lactate, and lymphocyte pleocytosis. The multiple PCR that was conducted on liquor showed the presence of DNA of herpes simplex virus 1. The patient started immediately aciclovir 10 mg per kilo plus levetiracetam because of tonic-clonic seizures. And after 21 days of therapy, a follow-up lumbar puncture was performed, and this time the DNA of herpes simplex virus 1 was not found. But after 7 days, the condition of the patient suddenly worsened, with head deviation to the right, abnormal bilateral corneal reflex, and clones on the right hand. An electroencephalogram was then performed, and it showed electrical activity that was consistent with non-convulsive status epilepticus. A combination therapy with multiple anti-seizure drugs was started, levetiracetam plus valproic acid and lacosamide, with a resolution of convulsive status epilepticus. But again, 4 days later, the patient condition worsened again, with a progression to septic syndrome and septic shock that required fluid resuscitation and initiation of vasopressins and orotracheal intubation after admission to the intensive care unit. Because of organ dysfunction, the patient also presented acute renal failure, and continuous renal replacement therapy was immediately initiated. A combination antimicrobial therapy with daptomycin and meropenem was then started. Hematology and biochemistry tests were remarkable for severe neutropenia, 80 cells per microliter, and elevated C-reactive protein and procalcitonin. Urine antigen tests for Legionella and Streptococcus pneumonia were negative, and this is the results of the TC scan that show confluent multiple alveolar opacity in the lower lobes and the medium right lobe with a bronchogram. The patient underwent fiber optic bronchoscopy and bronchoalveolar lavage. Multiple PCR that was done on the bulb fluid showed the DNA of Staphylococcus aureus, and detection of a resistant gene were positive for MAC-A. So it was very, very probable that the pneumonia was caused by Staphylococcus aureus with a phenotype of methicillin resistance. Moreover, because the patient had from the very beginning severe neutropenia, we hypothesized that this Staphylococcus aureus was also a penton-Valentin leukocidin producer. Blood cultures were withdrawn before the initiation of empiric antimicrobial therapy, and they were immediately checked in. After 20 hours, they turned out to be positive for gram-positive cocci. Molecular ID identified the presence of Staphylococcus aureus in blood, and gene detection was positive. Resistant gene detection was positive for MAC-A. So the empiric antimicrobial chemotherapy was revised, and the patient was and meropenem and daptomycin were stopped, and the ceftobiprole 500 mg 8-hourly continuous infusion was started. After 48 hours, the antimicrobial susceptibility test of the Staphylococcus aureus isolate was available, and this is the result of the AST that confirmed the phenotype of methicillin resistance. Follow-up blood cultures that were immediately withdrawn after the initiation of antimicrobial chemotherapy were negative. So, after the availability of AST, definite therapy was still continued with ceftobiprole 500 mg 8-hourly continuous infusion. The reasons why we chose to continue monotherapy with ceftobiprole was based on many data. First of all, the evidence that complication in Staphylococcus aureus bacteremia are significantly associated with an unknown source of Staphylococcus aureus bacteremia. But in our patient, this was not the case, because the source of infection, the source of bacteremia was known, and Staphylococcus aureus came from lung. Moreover, our patient blood cultures in our patient turn out to be positive after 20 hours. And we know from the literature that a shorter time to positivity of blood culture in Staphylococcus bacteremia, namely less than 14 hours, is associated in a statistically significant way with endovascular source of infection, and regarding the outcome, a shorter time to positivity is associated with a metastatic complication and high mortality. In fact, in this important study that was published in 2019, patients with Staphylococcus aureus bacteremia were categorized according to the duration of bacteremia in patients with short, 1-2 days, intermediate 3-6 days, and prolonged more than 7 days bacteremia. And patients with prolonged bacteremia were more likely to experience a metastatic complication, and they were burdened by a higher 30-day mortality rate. In fact, in patients for whom blood culture were withdrawn every day, every single day of positive blood culture were significantly associated with an increased 30-day mortality. Here you can see another study that was published in 2020 by Kuhl and co-workers. The authors demonstrated that patients with more than 1 day of bacteremia were burdened by a significantly increased mortality. And the cutoff of 2-day duration was the earliest cutoff that was associated with the highest adjusted hazard ratio of 90-day mortality. Moreover, patients with persistent bacteremia were more likely to present secondary foci of infection that were not observed at the initial workup. So the authors of this study concluded that it is very important to redefine the cutoff duration for persistent bacteremia that, I remember to you, is associated with increased mortality as 2 days. And follow-up blood culture, therefore, should be performed after 24 hours of initiation of adequate antimicrobial chemotherapy. But this was not the case of our patient because follow-up blood cultures were negative. The other reason why we use the ceftobiprole in monotherapy in patients with secondary Staphylococcus aureus bacteremia is the result of the study ERADICATE on patients with complicated Staphylococcus aureus bacteremia treated with ceftobiprole. The study showed that ceftobiprole is not inferior to daptomycin regarding to the primary outcome, so survival, symptom improved, Staphylococcus aureus bacteremia clearance, absence of new foci of infection. But it is also very important to note that in the group of patients, ceftobiprole treated patients, less patients still had positive blood culture after 10 days of treatment, as opposed to patients in the daptomycin group. So this is the workout, the algorithm that we use in our institution when we deal with a patient with Staphylococcus aureus bacteremia. First of all, it is necessary a thorough medical history, physical examination, and it is very important, we have just said it, to repeat blood culture and to do an echocardiography, transthoracic echocardiography. Then we stratify the risk for metastatic infection and complicated bacteremia. This risk stratification is based on predisposing host factors, such as, for example, the presence of foreign material endovascular foreign material or prosthetic valves, for example, the features of bacteremia, such as duration, community acquisition, time to positivity, and presence of marker of Staphylococcus aureus bacteremia, such as interleukin-1 beta and interleukin-10 that are routinely measured in our institution, and the clinical course, persistent fever, the unknown source of infection, signs of metastatic infection. Based on this evaluation, we categorized, use a combination of daptomycin plus new generation beta-lactams such as ceftobiprole. And we also continue the diagnostic workup, of course. The other reason why we use the ceftobiprole in monotherapy is the evidence from this study that ceftobiprole is not inferior to the combination of linezolid plus ceftazidime in treating patients with HAP, non-VAP, and ventilated HAP, patient with a hospital-acquired pneumonia that underwent later in the course to orotracheal intubation. And it is very important to note that patients with ventilated HAP show very high cure rates in the ceftobiprole group compared to the linezolid plus ceftazidime group, both in the intention to treat population and in the clinical evaluable population. Moreover, also ceftobiprole was not inferior to ceftazidime plus linezolid in regarding microbiological eradication, both in HAP. It is also very, very important to highlight here that when we deal with Staphylococcus aureus with a methicillin-resistant phenotype, we generally deal with a population of bacteria in which the resistance can be homogeneous or heterogeneous. Most clinical isolates are heterogeneous, which means that the population has subpopulation with differential expression of oxacillin or methicillin resistance. The growth of heterogeneous strains in the presence of beta-lactam can lead to selection of a homogeneous phenotype. This homogeneous phenotype can be selected by beta-lactam that bind to PBP1, and probably this homogeneous phenotype is selected by the hyperexpression of PBP1, PBP2, PBP2A, and PBP4. Ceftobiprole, with its unique ability to bind to whole PBPs of Staphylococcus aureus, probably is able to reduce the occurrence of a homogeneous resistance phenotype. And this is very good for our patient when we use this drug. So based on all this evidence, we decided to continue antimicrobial therapy with ceftobiprole 500 milligram every 8 hours via extended infusion 3 hours. We also added to the antimicrobial regimen linezolid, because from the very beginning, you can of course remember it, we hypothesized that Staphylococcus aureus was a producer of penton-valentan leukocidin. Please note that even though the patient was under continuous renal replacement therapy, we initiate with a full dose of ceftobiprole. This is because during an infection, especially during pneumonia, patient may experience a transient acute kidney injury that generally resolves within 48 hours. So we generally does not reduce the dose of a drug, even if the patient has acute kidney injury. Of course, when we speak about beta-lactams, even if for the first 48 hours. After the first 48 hours, the dose of ceftobiprole was decided based on a TDM-guided strategy. And after 3 days, we reduced the dose to 500 milligram every 12 hours. We decided to send the Staphylococcus aureus isolate that we found in the lung to the microlab for nanopore whole gene sequencing. And we were able to demonstrate that our isolate was harboring SEC-MEG type 4. So it is very probable that this isolate was a community-acquired methicillin-resistant Staphylococcus aureus. According to our first clue, we decided to perform a PCR reaction to look for a penton-valentine leukocidin, and we found it. We demonstrated the production of the expression of the gene of the penton-valentine leukocidin. Penton-valentine leukocidin is composed by two components that are coded by two different genes, LeucSPV and LeucFPV. These two components can assemble and form an heptamer, and when there are very high concentration of PVL, these heptamer are able to cause cell lysis that leads to tissue damage by release of inflammatory mediators or reactive oxygen species. But when penton-valentine leukocidin is present at low concentration, it is able to trigger an apoptotic pathway by binding to mitochondria membrane. Penton-valentine leukocidin is produced by methicillin-resistant and methicillin-susceptible Staphylococcus aureus, and is produced by methicillin-susceptible Staphylococcus aureus in a hospital setting and in a community setting. It is important to stress that the mortality of patients with pneumonia due to penton-valentine leukocidin positive Staphylococcus aureus is related to the grade of neutropenia and to the presence of erythroderma in the first 24 hours of admission. We decided to add linezolid to the antimicrobial regimen because of its ability to suppress protein synthesis, and because there are many animal models that show that early administration of linezolid is able to reduce the expression of penton-valentine leukocidin in infection in pneumonia due to Staphylococcus aureus with producing of penton-valentine leukocidin and increase survival. So in our patient, the choice of initially empirical and subsequently targeted treatment with ceftobiprole was based on evidence showing the non-inferiority of ceftobiprole compared to the combination of ceftazidime and linezolid in treating a ventilated HAP. Specifically, ceftobiprole, when compared to other antibiotics, is characterized by the unique ability to bind to all the PBP of Staphylococcus aureus, and we also decided to add linezolid because of its ability to suppress the production of Staphylococcus aureus exotoxin, such as, in this case, penton-valentine leukocidin. Thank you very much for your attention.
Thank you. Thank you, Professor Simmons, for your wonderful talk. I think through your case sharing, you shared with us the expertise as how to treat MRSA, HVP, as well as the bloodstream infection, and how to optimize the treatment. So after the immune suppressant treatment, the patient had the infection and had a HAP infection. And so after molecular diagnosis, the patient has been confirmed with MRSA infection and bacteria carried MAC-A gene mutation. So initial treatment was the meropenem with daptomycin, and then the patient was switched to the cephalosporin, and after the treatment, the patient improved. According to the paper review, he also shared with us that for the MAC-A infection, and so if the infection duration is long, the patient has poor prognosis. And actually for MRSA infection, according to the New England Journal of Medicine's paper, compare against the daptomycin, cephalosporin is comparable with daptomycin. It is well worth of utilization. And also in the end, Professor Simon also shared with us a lot papers saying that actually in the beginning, the patient was on monotherapy, of the cephalosporin, and because the bacteria has the production of the PVL, that's why we combine cephalosporin with the nilosolide. So I think this is very important. And I think Professor Thiemann combined clinical practices and basic studies, and also the gene sequencing and testing, which also assisted the clinical treatment. Thank you, Professor Thiemann, for your wonderful talk. Now we will enter into the panel discussion. So in this part, we do have some panelists. They are Professor Carlo. Professor Carlo is from University of Wood Medical School, and he is full professor in infectious disease, and he's director of specialty school in multi-infective medical intern program, director of infectious disease clinic, member of the steering committee of SITA, member of the SIMIT, and member of the CMND, and also has many other important academic titles. The second panelist is Professor Luo Hong, and she is Professor to Physician Grade 1, Doctor Supervisor, and also Director of the RSIU, and she is also member of the Respiratory Critical Care Group of Respiratory Disease Branch, member of the Internal Medicine Physician Branch of Chinese Medical Doctor Association. She also has many other important academic titles. Third panelist is Professor Fang Wei, and who is also chairperson of today's meeting, Chief Physician Doctor Supervisor and Postdoctoral Supervisor. And she has many important academic titles. We're also very happy to have Professor Zhang Jichen join us as the panelist. He is the Chief Physician, and he's from Shandong Provincial Hospital, member of the Critical Nephrology Group of Critical Care Medicine Branch of Chinese Medical Association, member of the Extra Corporate Life Support Committee of Chinese Medical Doctor Association. He also has many other important academic titles. The fifth panelist is Professor Chu Jian. He is from Second Shanghai Hospital, Central South University, Doctor Supervisor, Associate Researcher, Associate Professor, Deputy Chief Pharmacist. He is member of the Precision Medicine Branch of Chinese Society of Cardiovascular and Thoracic Anesthesia, member of the Precision Pharmacy Service Committee. So now I will give the microphone to all the panelists to share their comments with us. And Professor Cao, you first, maybe.
Yes. Thank you very much for the invitation. So I have few comments because Professor Giuliano is working with me in the same word. I just would like to outline the importance to inhibit different penicillin binding protein, because normally we think that to inhibit only one penicillin binding protein, it's good to be bactericidal, to kill the bacteria. Instead, we are understanding from Enterococcus faecalis that inhibition of more than one penicillin binding protein is very useful to be bactericidal for the combination of beta-lactams that are able to inhibit more than one penicillin binding protein. And also in gram-negative, there are some report of efficacy of combination of beta-lactam to inhibit more than one penicillin binding protein. In the case of ceftobiprole, in the case of a Staph aureus, with only one molecule, we are able to inhibit more than 3 penicillin binding protein, including PBP2A. So this is a new way to use antibacterial. In this case, then, because of the demonstration of Panton Valentine production, we added linezolid to reduce the production of protein and toxin. And this is, for me, the most important things in the most important point, key point on this clinical case. So in our hospital, we are able to measure ceftobiprole, and in different cases where we don't need the linezolid, like in this case, monotherapy also for pneumonia, we use a lot because we were able to measure in the blood the concentration of ceftobiprole and also of other 20 antibiotics. For us to measure antibiotics in the blood is practical clinical, is a normal clinical practice, everyday clinical practice. And also in more severe cases, we use off-label, obviously, because we are able to measure in the blood, and we know that in case of augmented renal clearance, we may increase the dose and we may administer better ceftobiprole using continuous infusion. We have published recently a paper with colleague of Bologna, Professor Pea, demonstrating that also for MIC up to 2, we are able to reach high concentration and target attainment for clinical efficacy. So these are my comments. Thank you very much.
Thank you.
Thank you. Thank you very much. So I think today is indeed International MDT, and we're very happy to have the 2 Italian professors join us. And Professor Simon just shared with us very wonderful case, and also Professor Infectious also shared with us the comment and for Staphylococcus aureus diagnosis and treatment. My personal feeling is that for our Italian experts, they have done very good clinical and basic studies. And for the Staphylococcus aureus, they will do gene testing, because for the infection of the Staphylococcus, they have different types of the methicillin binding protein. And for cephalosporin, this is a new generation cephalosporin drug. The advantage of this drug is that for Staphylococcus aureus infection is highly heterogeneous. So the advantage of cephalosporin is that it is able to bind different methicillin binding proteins. So for different proteins, it is able to be binded with them. So when we utilize cephalosporin, it is very potent. And actually, from this case, what I have learned is that they have done very good basic studies. They have done gene testing with the PVL production. So that's why they add on the linaclide. So this is not just about the cultural result. And like, for example, for the MASA, we would usually utilize the vancomycin for pneumonia as well as the blood infection cases. And if we can do those gene testing, we can be more precise, and we can identify the source of the resistance issue for Staphylococcus aureus infection. So I do have many takeaways from this case sharing. So I think from our Italian colleagues, I do have many important takeaways. So I think we also need to communicate more with pharmacists, including TDM surveillance, and also together with Professor Chu and Professor Xu, we also can do some joint work, because for precision treatment, we really need to learn from our international colleagues. So I think this is my personal feeling. Thank you. Thank you very much. I also want to thank the 2 Italian professors for your kind sharing. Thank you.
Thank you.
Okay, Professor Fang, please. Professor Fang Wei. So I think Professor Fang had some connection issue. Professor Ji Chen, are you online? Okay, respected experts, distinguished guests, good evening. It's my great honor to have the joint discussion with all the distinguished experts from the ICU field as well as the intensive infection field. And it's also my great opportunity to learn from the international experts. So today we focus on the gram-positive bacterial infection, cephalosporin. Is a new drug in this field. Just like previous speakers mentioned, in China, actually, we had a lot of the gram-negative bacterial infection. However, according to 2023 data, the gram-positive, especially the Staphylococcus aureus infection, it has been ranked as the third infection bacteria, and for MASA, it is also very common, especially for community-acquired infection, because in hospital in the ICU, what we see a lot is the gram-negative infection. For MASA, we also encounter a lot of the clinical cases. And in China, we also have a lot of vancomycin-resistant bacterial infection or the multi-drug resistant cases. Actually, the resistant cases may not be that large, and normally they can be susceptible to vancomycin and the other related drugs. And for cephalosporin, I understand this is a new drug.
And I learned from previous speakers the MOA of cephalosporin. It has a low resistance rate, and it is a new generation of cephalosporin. It can cover the gram-negative some pathogens. So for those with resistant coccus and gram-negative bacillus, it shows very good efficacy. For cephalosporin, it has a very few toxicity. In China, it is currently available. In May this year, we tried this cephalosporin in one of my patients. And then my patient has not a very good cardiac function with some other organ infections. So not very good liver and renal function. And we have a coccus resistant one, and also has a very low level of a platelet. We try cephalosporin for a couple of days, but the patient have a sudden worsening of a liver function. We don't know why, because it is a new drug, and then we just try for a couple of days. Generally speaking, it's very effective for coccus, but because only a couple of days were used, we don't have a long-term data. Generally speaking, it is a novel drug to us. With today's learning, I know more about the mechanism, the indication, and how to use it. And also, Professor Gliano also introduced some of his cases, and we know how to use it wisely. And we know a lot from your research data. And maybe in the future, cephalosporin can provide more blessings to our patients, because we don't have that rich experience in using it. So I'm here today to learn basically from you. And for the wide spectrum drugs in ICU, a lot of patients have a mixed pathogen infection, especially in those with uncertain pathogen. Use an agent that have a wide coverage of a spectrum can be a good selection, especially in ICU patients. We will see those with impaired organ function. We do hope that with the new drug, which has a wider coverage, better efficacy, and lower toxicity, can provide more benefits to ICU patients. That's all from me. Thank you, Chairman. Thank you, Professor Zhang, for your sharing. Now let's welcome Professor Chu. Okay, thank you, Professor Gliano, for your wonderful presentation and case sharing. Well, I really learned a lot. For this case per se, for Staphylococcus aureus leading to toxic syndrome, that's why you add on linezolid. You show very good efficacy for the PVL production. We know not only for Staphylococcus aureus, for the sensitive assay, it will produce more of such toxin. But the MRSA leading to the toxin is not uncommon. I encounter some cases similar MRSA that led to TSS and also the Streptococcus lead syndrome with a compressed toxin. It can kill the bacteria, and also clindamycin can have a role to play. You have done genetic testing and also PVL related genetic testing from bench to bedside. You gave us a very elucidated information about the case. We all learn a lot from your presentation. I do have two questions to ask you. For bloodstream Staphylococcus aureus infection, according to FDA guideline, for day 1 and day 8, we can use 0.5 Q6, but you use 5 milligram Q8 hour. What do you think about the dosage? Second question is that the patient is undergoing CRRT. You're using 500 milligram Q8 hour. For CRRT patients, which mode is the CVV mode, or what mode is the CRRT patients you are using? Do you have experience in CRRT patients? What about the dose? Will you do TDM and change the dose according to TDM results for CRRT patients? That are two questions for Professor Gliano. Thank you.
Okay, thank you very much for your question. Regarding the dose and the dose we use in patients not undergoing continuous renal replacement therapy, we generally base the dosing regimen on TDM. Both in patients that are not under renal replacement therapy and in patients that are under renal replacement therapy. So the dose that we use, and we change the dose according to the result of the TDM. Generally, we do the first sample, we draw the first sample after the third dose of ceftobiprole, and we have the result of the TDM. If we take the sample, and in the morning we have the result in the afternoon. So we are able to change eventually to change the dosing regimen very quickly. Regarding the type of continuous renal replacement therapy, I don't have data on the flow rate that the patient was under. I don't know actually, so I cannot answer to you. I'm sorry for it, but I don't know. But generally, I have a lot of experience of using ceftobiprole in patient on CRRT, and the pharmacology helps me a lot because every dosage is based on the TDM strategy, is based on a TDM guided strategy.
Thank you so much for your answers. Okay, thank you, Professor Gliano, for your great answers. Professor Chu, you have other question? Because for the CRRT mode, maybe as an infectious physician, we don't care too much about the mode, but it maybe have some association. Maybe later we can conduct some research to see maybe there are correlations between the CRRT mode and the dose adjustment. Okay, thank you all, our panelists, for your discussion. Now let's enter the next agenda, which is a case sharing. Professor Yang Hongna will give us a case sharing concerning Staphylococcus aureus pneumonia. Professor Yang Hongna is from Shandong Provincial Hospital, Associate Chief Physician, Master Supervisor, Associate Researcher, Associate Professor at Shandong University, Chinese Medical Association, Critical Care Young Scientist. She presided over a lot of studies and published abundantly. Over to you, Professor Yang, to share with us your case. Thank you. I would like to share my screen now. Thank you, Professor Jiang, for your kind introduction. Can everybody see my slides? Yes, please proceed. It's my great honor to present you with a case of SAP, or Staphylococcus aureus pneumonia. And we are actually a MSSA leading to a CAP, not a MRSA. It is a post-COVID era case. At this opportunity, I'd like to share with you more details for more discussion, some of our thoughts, because there are some questions confusing me. The first part, case report. 36 years old, Madam Zhang, chief complaint fever for 7 days. Very simple. And chest stress and asthma for 1 day. Admitted on December the 15th. Previously very healthy. Only C-section was done. And on the December the 8th, there was onset of a disease, no cold, no fever, no a lot of pressure or anything else. The T max was 41 degrees Celsius, no rigor, no chill, but there was a sputum and with some blood. And there are no other signs to be noted. For other hospital, for symptomatic treatment, we don't know about the detail of the infusion, but the patient got worsened and exacerbated, and there was a distress on the chest. 3 days later, there was a chest pain, repeated fever every day. It was 39 to 41 degrees Celsius. In the local hospital, there was a CBC checkup. There was a decrease of a white blood cell, significantly lower than healthy people, CRP high, PCT high. So the linezolid, levofloxacin, and imipenem were given, and also acetaminophen was given for antivirus efficacy. There was a high flow oxygenation. And so for antiviral, antibacterial, and the body temperature got resolved. The max and the peak temperature was 38 to 39. And 3 days later, there was a palpitation, chest tightness, confusion, and also significant respiratory distress. And with a non-invasive ventilator, assisted ventilation, the respiratory distress and confusion was not improved. That's why I committed to our hospital. pH 7.21, PCO2 very high, PO2 101. So in the ER, we gave the patient tracheal intubation and a ventilator. And then the PO2 got increased. Physical exam, there was anesthetic sedation, ventilator-assisted ventilation with the oral tracheal intubation. Breath sounds were coarse in both lungs and scattered dry and moist rails could be heard. So admitted to our department, you can see the CT chest bilaterally, there was a diffusive extrusion. So this is the CT. The diagnosis upon admission was severe pneumonia. We thought it was a CAP, a community-acquired pneumonia. In the local outpatient clinic, there was a Staphylococcus aureus infection. We gave this patient other diagnostic workup there to promote suction of the sputum, and these PO2 was 100 to 150. According to the algorithm, we titter the oxygenation, and there was a prone position ventilation. Bacterial, antibacterial wise, according to the NGS, this is a SA confirmed. Combined with the imaging test, we give this patient vancomycin and also the moxifloxacin. There was a pneumonia. We cannot rule out other pathogens, so we give this patient vancomycin. Others are supportive care. Coming to our department, we checked the pathogen. This nucleic acid showed a mildly positive for type 1 influenza. And according to the NGS, we show pretty much confirmed the SA. So on the second day, in the BALF or above, there was clindamycin resistant Staphylococcus aureus. This is MSSA, we thought. Well, as you can see, there is a large quantum of a yellowish, very sticky sputum in the small airway, very significant flow of a sputum. Currently, for the immunology and the pathology, it is a SA-led CAP. But the third day upon admission, there was no significant improvement of oxygenation. So the fever was still going on. The peak temperature was around 38, but the third day on admission, there was a worsening of lung function, and that's why we give this a patient CRRT.
And actually, for the staphylococcus infection, we utilized antibiotics. And actually, for the antibiotics, it is able to cover the infection of the Staphylococcus aureus. However, spilling cultivation, we had the positivity of the Baumannii Acinetobacter. So back then, we were suspicious that with the combination of the two infection, with the change in the pulmonary changes in the images. So for the Staphylococcus, Staphylococcus aureus, it has very high virulence. And also, we were suspicious of the resistance gene. So actually, for the Acinetobacter baumannii, it was the colonized bacteria. However, the patient had decreased oxygenation index, and so in the 29th, and the patient had further decreased the oxygenation. And actually, for the carbon dioxide, we were not able to reverse that. And for bilateral lung, we also see extensive white lung lesions. And so whether we need to utilize the ECMO for this patient. And so if the oxygen is less than 200, 150%, actually we need to utilize different oxygen therapies covering from mask oxygen therapy to high flow oxygenation, etc. And the patient is indicated for ECMO. So we utilize the ECMO for this patient. And actually on 20th December, we switched on ECMO or the CT. And so this is the CT on 23rd of December, and the patient had the halos. And so we thought that it was caused by infection of the Staphylococcus aureus. That's why we kept vancomycin. And actually on 30th December, the patient improved oxygenation. And here we can see that we began to clamp off the gas flow and oxygen concentration, and we did another chest CT for the diffuse oxidase. It has been dissolved. However, we still see a lot of the halo imaging signs, and we actually waived off the ECMO. However, the patient had a fever again. The patient had a high fever, and also actually for the oxygenation also improved slowly. And here you can see ventilation has also been improved, except for the left lower lobe. Actually, for the rest of the lung, we see huge improvement. Actually, on 6th of January, the patient has been constant improvement. However, the patient had a poor outcome, and the patient died of the bloodstream infection. And so we see the patient that have the blood infection of the Acinetobacter baumannii, and the patient died of this infection. Well, and because after the opening up of the pandemic, which was in the end of 2022, so after the first half of the 2023, we see a huge decrease of the COVID severe pneumonia. However, we see the MSA-induced severe pneumonia. So we thought about the 3 questions for MSA-induced pneumonia, whether it is related with specific background environment, because this is right after the pandemic of COVID, and the patient had a combination of influenza infection. So I think maybe because of the pandemic, it has compromised the immunity of many people. And the second question we thought about is the bacteria for MMSA. It has the independent change or mutation of the gene, which increased the virulence, and also the speed is of infection is also quick. And third one is the host factor, because after pandemic, many people have the compromised immunity. So actually, in 2023, we also experienced the outbreaks of respiratory disease in the second half of the 2023. And even though for pediatric patients, they back then didn't have high or severe infection of COVID, but they have a lot of the mycoplasma, pneumonia in the second half of 2023. And so actually after we open up after the pandemic or mitigate the restriction or shutdown for the pandemic, and we have the immune gap and immune debt that has caused the outbreak of the Mycoplasma pneumonia. And because for the social restriction situation, we didn't have the stimulation of the immune systems, and so which increased the susceptibility of the respiratory pathogens to the children. And so we have the immune gap. The immune gap is that WHO experts help to explain the epidemic of the diseases in China and describe the current immune level in China as different from the past with the gap. And they do have some evidences to support that. This is the evidence from New Zealand. Actually, in 2021 April, New Zealand partially relaxed the strict border closure to allow travel between Australia and New Zealand. And then they saw rapid outbreak RSV cases in New Zealand. And also the number of surveillance cases RSV in New Zealand was as much as 5 times higher than that from 2015 to 2019. The number of the ICU cases of bronchiolitis caused by RSV in children aging between 0 to 4 also 3 times higher than in the previous year. So I think during the pandemic, we had a lot of restriction factors. We wear masks all the time, which compromised our immunity. So I think for respiratory system, actually, it is also an immune organ, and actually they do have the crosstalk with the peripheral immune systems. So back then, we thought about the effects and impacts from respiratory immune system, whether it's related with the coronavirus and for the 3 years pandemic of COVID for MSA infection, shall we or are we able to observe the increase of it? Actually, in 20th century, we see a lot of of the epidemics, and actually, in 2003, we had the SARS, and back then we also had outbreak MSA pneumonia, and actually, in 2021, we see reports of the occurrence of MSA pneumonia after the COVID, and also for the MSA susceptible Staphylococcus aureus. Well, just like Italian professor mentioned, the PVLP Staphylococcus aureus strains can cause rapid hemorrhagic necrotic pneumonia, mainly in otherwise healthy children and young adults. And the pneumonia is often preceded by influenza-like symptoms, has high mortality rate. So from this point, we know that the patient is a female with quite young age. The patient had the infection of the Staphylococcus aureus. The patient had very quick progression. Even though we improved the pneumonia for this patient, however, due to other reasons, the patient had a bloodstream infection. The patient died of the bloodstream infection. And we want to understand whether the certain environment has caused the peak of the MSSA infection, because back then we have 5 MSSA induced severe pneumonia patients, and we see male, female patients that are also young. Some of them died. So we compare the situation before and after the pandemic in 2019. For the isolates, the Staphylococcus aureus is the 5th infected ones, and the proportion is around 90% in the respiratory samples or other samples for the before the pandemic. It is the 5th infected virus, and also in 2023 for Staphylococcus aureus isolates, it is the 3rd infected. And so for the isolates, if we utilize that to do the prevalence calculation, I think it is irrelevant with the pandemic. And actually, in America, they also had the similar observation. They observed MSSA hospital-acquired pneumonia, and so before and after the pandemic, they also think that after pandemic, the MSSA bloodstream infection has been increased. However, it is not the same for the pneumonia. And also for complications as you still about the bloodstream infection, the coagulase negative Staphylococcus enterobacteriaceae. So we cannot utilize the COVID infection to explain the increase of the MSSA infection rise. And this is the Chinese epidemiological study. Here you can see, and this is from 2009 to 2020 in CAP for Staphylococcus aureus, and we didn't see the increase. However, for severe CAP, namely patients about 60 years old, the prevalence of the infection is actually increased. The interesting phenomenon that we have observed is that from 2009 to 2020's cases versus the COVID pandemic cases, we observed that during the pandemic, the Staphylococcus infection rate has been decreased. And also right now, etiological or epidemiological evidences cannot support the concept or the hypothesis that the special environment induced the increase of the MSSA infection. How about the second question we have? So for Staphylococcus aureus virulence, so the first source is the coagulase, the second is endotoxin, and the third one is the toxic shock syndrome toxin. Fourth one is the PVL. For PVL, actually in young patients, they're gonna have the outbreak of the pneumonia. So according to the study, for 43 patients with necrotizing pneumonia, we have the detection of PVL-produced Staphylococcus aureus. Severity is only 46% with very high mortality rate. So I think maybe we can utilize this concept to make the explanation why the MSSA-induced pneumonia has very high mortality rate. Another situation about this patient is that the patient had the MSSA infection as well as the virus infection. So we check the combined infection situation. They having the mutual inhibitory or mutual stimulatory effects. So we checked this paper. They study pathophysiology mechanism of the PVLP Staphylococcus infection. Actually, virus infection activates the lung epithelial cells, release large amounts of cytokines, and induces immune cell influx. Therefore, actually, in the superinfection where PVL produces Staphylococcus aureus, leukocyte replicated immune cells recruited by the virus, and the neutrophils release proteins, resulting in tissue destruction. Clinical manifestations of necrotizing pneumonia. So if we have combined the infection of the influenza A with MSSA or Staphylococcus aureus, they will further enhance the damage to the lung tissue, and which will further increase the virulence of the virus. And that's why it is explained that the patient died ultimately. And actually for MSSA, the prevalence is actually on the rise. Before that, I also identified a very interesting paper, and this paper has been published by the Tongji colleagues in Shanghai. In RCU, we talk a lot about MASA. However, in this study, nowadays we have more reasonable utilization of antibiotics for MASA, even though prevalence is still quite high, but the incidence is actually decreased. For MSSA, the incidence is actually on the rise from 2008 to 2018. For Staphylococcus infection. And according to their observation, ST5, the virulence is on the rise for ST5 strain, whether it has different virulences. So in the study, they have the ST5 positive Staphylococcus inoculated to the nude mice. And so for the ST5 positive MSSA and compare that against the MASA, and for the mucosa damage, the MSSA has more severe damages, which is even severe than the MASA in the first, second, third mouse, and you identify that they have more severe mucosa damages, and actually, and the skin concentration is also higher than MASA, and for the A549, it is a cell line And also they did this cultivation. They found that for MSSA, they have more emphasis on adhesion capability. So for MSSA, once it is infected, it will be adhered to epithelial cells in the respiratory system, and so which will change the permeability of the lung tissue. And so for ST5 positive strain, the virulence is increased because of the higher adhesion capability, and vice versa. For the infection of those strains, we're gonna have more severe pneumonia. So based on those information, we also want to hear from you about your experiences for MSSA-induced pneumonia. What about the severity and mortality in your center? Because right now we actually we don't have a lot of those cases, and so for ST5 strain, virulence is also increased, and so I think maybe this is the amplification of the original strain virulence, and also I understand because the patient had infection of bacteria and virus at the same time, and maybe this worsened the patient's case situation, and the patient ultimately died from this infection.
Thank you, Professor Yang, for your case sharing for the MSSA, and you gave us a lot of information concerning why after COVID period it is more prone to MSSA with a higher virulence, higher mortality rate, and fatal rate. Now let's dive into the second discussion session. Please share with us your point of view and comments. And our panelist for this session is Professor Carlo. I've already introduced him. I will not elaborate about our panelists. The second one is Professor Simon, and the third one is Professor Xu Ping. Professor Xu Ping is our moderator from the Second Xiangya Hospital of Central South University. PhD professor, senior chief pharmacist, level 2 pharmacist, doctor supervisor. She has a lot of titles and different responsibilities in associations and societies. And the next panelist is Professor Chen Jinglan. Professor Chen is from Second Xiangya Hospital of Central South University, doctoral candidate, chief physician, master degree supervisor, and she's a visiting scholar in Davis Medical Center. She holds a lot of titles in different societies as well. The next one is a Professor Deng Ming Yang, who is from the Second Xiangya Hospital of Central South University, Associate Chief Physician, Associate Professor, Master Supervisor, and also is a Deputy Director of the Hematopoietic Stem Cell Transplantation Center at the Xiangya Second Hospital, among other titles. Now let's welcome our panelists to share with us your comments. The first one, let's welcome Professor Carlo, please.
Yes, thank you again for this second case. Very, very interesting. To be honest, I had some problem to follow all the details of the case because some slides are, some reports are in Chinese. So I summarize. I understand this young woman with influenza pneumonia and MSSA necrotizing pneumonia. So in this case, is very, very frequent that the MSSA may produce Panton Valentine. So if I understand correct, the patients was treated with vancomycin and moxifloxacin. And my first comment is that although moxifloxacin may be active against Staph aureus, it depends on the MIC, and I did not understand how was the MIC of moxifloxacin. For the second comment is about vancomycin and MSSA. There are some reports from some retrospective study that say that for MSSA, vancomycin is less active than beta-lactams. We know that if we use beta-lactam against Panton Valentine producing strains, we may increase the release of the toxin. So in this case, we have added antibiotics that stop protein synthesis, like clindamycin, but I understood that was resistant, although linezolid may be an alternative option, and the patients was treated in the first days with linezolid. We have to notice that there are some strains in the States, especially in children, non-adults, that are MSSA, methicillin susceptible, but also penicillin susceptible. So we stopped to test penicillin because in the last decades, until 2000 a year, the penicillin susceptibility rate was less than 10%. But now, the more severe cases in children in the States are caused by MSSA penicillin susceptible, up to 30%. So maybe very useful to know penicillin susceptible in these strains, because someone hypothesized that the use of daptomycin, that is similar to natural cationic peptides that we have in our tissue, increase the permeability of these strains that release the penicillinase enzyme, and so they are penicillin susceptible. In these cases, virulence is higher, and also the activity of glycolipopeptides may be less bactericidal. So bedside, when you have a very severe case of MSSA, penicillin susceptibility may be helpful. To be honest, I didn't understand this because the results are in Chinese. Thank you very much. Hello?
Yes, we can hear you. Yes, for the susceptibility, it is resistant to penicillin. So that's why.
Thank you very much. Thank you.
Now let's welcome Professor Simon. Any comments? Professor Glignano?
Yes, I'm here. Yes, I have a comment. If I have understood well the presentation, you presented a case of pneumonia after influenza virus infection. COVID-19, but also influenza pandemics in the past have shed light on the interplay that exists between respiratory infections, viral respiratory infections, and fungal and bacterial lung infection. It is possible that we need to, in common clinical practice, we need to search for a respiratory virus when a patient comes to our attention because of bacterial pneumonia. I believe that the interplay is due to, as the lecturer also highlighted, by the fact that viral infection are able to reduce the activity of cell-mediated immunity. And in this case, I believe that because the isotype that is mainly affected by the viral infection is the T helper 1 isotype, it is possible that there is a reduction of the production of such important interleukins, such as interleukin-1 beta, and interleukin that is related to the activity of T helper 1 is very important in controlling the infection due to Staphylococcus aureus. So this can be it is just my opinion, but can be a perspective for future study. And I want to stress that it's very important to study the interleukin production, the cytokine production of the patient when the patient is affected by a viral infection, because it can give us clues on the possibility of treat also the bacterial infection, for example, by administering interferon gamma, for example. So just this comment. If you want to comment back, if I can, if you have something to say about it, I'm happy to hear you.
Thank you for your very wonderful sharing. And now let's welcome Professor Xu Ping. Right. Thank you for the chairperson's introduction, and I'd like to say thank you for Professor Yang's wonderful case sharing. Actually, it is a very young woman, previously very healthy MSSA patient for a community-acquired pneumonia. For Professor Yang's couple of questions, according to our pharmacist perspective, maybe for disease progression per se, Professor Carlo, Professor Simon has given us some highlights. But for the pharmacology perspective, there was one view for MSSA compared with the MRSA. What about their virulence? According to microbiology, there is one point of view. I also read some case series being reported. Actually, for one strain, in my impression, for Staphylococcus and Klebsiella pneumonia, and the wild type, not resistant strain, the virulence is higher than the resistant strain. That is according to the microbiology features, which is widely seen in nature. Before evolving to resistance, its virulence will be reduced at the same time. So not necessarily MRSA is necessarily have higher virulent than MSSA. That's my understanding. Sometimes the sensitive Klebsiella pneumonia is more virulent. The sensitive ones are more virulent, like what you have shared. The sensitive strains may impair organs, tissues, and cells more significantly. That's my understanding. Additionally, for the patient treatment, previously there was a MSSA lung infection, but if I recall correctly, you also mentioned that during admission and hospitalization, there was a sputum or bloodstream. There was AB or Acetobacter baumannii. So based on your reflection, there was a colonization but not infection. But very quickly, there was a circulation instability and also infectious shock. So maybe for the later treatment, I didn't follow you very quietly. What about later treatment? Have you treated the BA? Because Acinetobacter baumannii, this is a gram-negative bacilli, is unlike the positive one. It will have circulation instability earlier compared with the gram-positive ones. That's my comments. And then for MSSA per se, actually, like Professor Carlo and Professor Simon mentioned, I also read some literature. For MRSA, maybe vancomycin is more efficacious than beta-lactam. But for the sensitive one, on the other hand, MSSA, in particular, maybe vancomycin is not as efficacious according to clinical studies. So maybe we can use a beta-lactam And then you also mentioned this patient is resistant to penicillin. So for this patient, as such, we can consider maybe using oxacillin since it's sensitive to oxacillin. But in the lung, according to the lung CT, there is a cavity being seen, very severe one. But this is in hindsight, right? But for the patient, maybe linezolid or other alternatives could have been chosen. Why I consider it like such? Because, like you mentioned, beside the C section, in the past history, the patient was very healthy. For the 36-year-old, very young patient, I didn't know about the renal function. And why? Because for the severely or critical ill patient, for all of a sudden, they have a very acute worsening under stress. There was a hyperrenal function. If the patient have a hyperrenal function, the vancomycin concentration will be not reach to the target if the patient have a hyperrenal function. So I don't know about the TDM of a vancomycin at that time. That's my comment for your case, and thank you again for your sharing.
So I want to make some extra comments for this patient. Sorry, Professor Yang's connection is poor. So we had some discussion. The patient actually died of the bloodstream infection. Renal function was normal for this patient. And we also did the TDM. We utilized the vancomycin. And why we didn't utilize linezolid? Because the patient had thrombocytopenia upon the needs to the hospital. We utilized vancomycin. The patient had AKI, renal impairment. And so for severe cases, we also had some confusion. Actually, for the MSSA, actually, we should utilize the cephalosporin, which can be better than the oxacillin. However, we still utilize the oxacillin for this patient because of some combined factors. Thank you, Professor Xu, for your kind comment. Now I'd like to give the floor to Professor Chen Jinlan. Respected experts, good evening. I understand I had many important takeaways, but I was on business trip, so I was not there for the whole time for all the talks. I understand for hospital-acquired infection and pneumonia, and we rarely see MRSA. Normally, we see gram-negative infection. And for endocarditis patients, nowadays with the advanced detection technology, nowadays we identified some of the pathogens for the pathogens. We also sometimes did the NGS with NGS, and we were able to identify the pathogens that were not even in the textbooks in the past. What we are scared most is MRSA. If it is the MRSA-induced endocarditis, they have very quick progression because for endocarditis, if they have the acute hemodynamics instability, sometimes it will be emergent surgery. We received the MRSA-induced endocarditis. Upon the admission, the patient was in stable hemodynamic situation, except for that the patient had the mild situation, but the patient had sinus tract formulation, and the MRSA actually caused a very quick progression. And so from this point of view, the MRSA had very high virulences. In addition to that, for MRSA, normally we utilize the vancomycin in combination with the cephalosporin. And then after the surgery, based on the treatment duration, we utilize it for 4 to 6 weeks. And also, we normally utilize the routine antibiotics after 6 weeks of the treatment. And we need to emphasize on the eradication of the microbiomes, because if they don't have good inflammation control, actually the valve after valve replacement, the patient would have persistent inflammation in the neighboring tissue of the implanted valve, the patient will have the parallel valve leak. And because for the suture part, when we suture the valve to the neighboring tissue, in early phases it may work, but if they have persistent inflammation, the suture may be detached from the neighboring tissue. So they're gonna have the parallel valvular leak. So I think in addition to valve replacement, we do the inflammation control, and we also do this for many other surgeries. So vancomycin is the mainstay drug, and in the future, I think if patients still don't have full eradication after full duration of vancomycin, maybe we also try cephalosporin to treat them, and also we will see that whether it can have quick control of the muscle-induced endocarditis. So I think this is my personal experience that I want to share with you. Thank you all very much. I also want to thank Professor Xu, and I thank all the lecturers and 2 Italian professors. Today's session is indeed wonderful. Thank you. Thank you, Professor Chen, for your wonderful sharing. Now I'd like to hand over to Professor Deng Mingyang. Okay. Thank you. Thank you for your kind introduction. I also want to thank the speakers. And actually, I'm a hematologist. I don't do ICU care. For critical ill diseases, I'm not very familiar with that. For the hematological disease patients, they have compromised immunity. And also for the infection, they're also very complex infection cases. And also for infection treatment, we would bring in Professor Xu to offer guidance to us in terms of the hematological disease treatment. And we also have many important takeaways. Actually, for hematological disease, we have 2 important groups. One is the chemotherapy patients. The risk factor is the thrombocytopenia fever. And for those patients, it is not very difficult to treat. And for other infection patients, actually, we can utilize the carbapenem to treat the patients that with the infection of gram-negative bacteria. And also, according to our recent years survey, the neutropenia patients after chemo, the common blood infection bacteria is the E. coli, and also for gram-positive infection, we don't have a large number of those cases, and this is related with the PICC placement. And I do a lot of transplantation. For transplantation patients, they have very complex situations because originally the immunity will not be restored after transplantation. And the most difficult part one is the virus infection. So in Professor Yang's talk, I saw the post-COVID infection. I also have personal experiences with that 1 to 2 months after transplantation, and the patients would have the CMV infection. And if you don't control them, and they're gonna have the same pneumonia. However, for those patients in the very beginning, they would have the typical pneumonia changes, such as the type 1 respiratory failure, as well as the dyspnea. And sometimes they will not have very severe dyspnea at the very beginning. However, ultimately, they will not die of infection. And of virus, they will die of the bacterial infection, such as gram-positive or negative bacteria. We had similar cases with Professor Yang's case. Is that in the beginning, actually in CT image, you just see ground glass changes and interstitial lung disease changes. However, as time goes on, you will see massive exudates in the lung image, as well as the consolidative changes in those images. And it's very difficult to control. And also, when they have infection, and they would have the GVHD as well as other immune disorders. You also need to utilize immune suppressors to control the immune disorder, and you also need to utilize the anti-infection drugs to control the infection. So it's very, very complex. I also have done a lot of thinking in this way. So for those patients, if we utilize the antibiotics, can we truly eradicate the microbiome when they are in the immune compromised status? And because sometimes we have the coexisting status with those microorganisms. And for the rejection patients, and you do the cultivation, you will see positive of the fungi, bacteria, and virus. And so when you use antibiotics, it doesn't work, but we use the fecal transplantation and to, firstly detect the dysbiota in the GI tract, and then to supplement some some bacteria or probiotics in the gut. It may solve this problem because sometimes infection will overactivate the immune system to release massive cytokines. Inflammation would, on the other hand, cause damages to the tissue. And also, it's going to have a vicious circle, which will cause further inflammation. And so, if we only treat patients from the perspective of infection, so it's quite difficult to recover the tissue and also to inhibit the inflammation. So, and if we only utilize the corticosteroid to inhibit inflammation, it is indeed tricky. So that's all from me. Thank you very much. So I don't have any extra issue or comment. Thank you, Professor Deng, for your kind comment. For the interest of the time, I think we should end today's session. And I think for today's two cases, they are very wonderful cases, and we also have very good exchanges and communications. And we do have many important takeaways from today's meeting. So actually, we identified very good insights. We also identified some gaps which should be improved in the future. So now I will hand over back to two chairpersons to give us the conclusion remarks. Professor Luo. Thank you, Professor Jiang. So I will do a very quick summarization. Actually, tonight we had the intensive infection international MDT training program. It is very insightful and informative. So I think this is indeed a very valuable opportunity to have the exchanges with our Italian experts, especially to focus on gram-positive bacterial infection. So today we had two cases sharing, and Professor Chu shared with us the pharmaceutical features of the cephalosporin, and for the other two speakers, they give us very good case interpretation. And we have done a lot thinking because for the audience, we are working at the forefront to battle the bacterial infection. We see patients that are in compromised immunity status. So we do have many important takeaways. I want to thank the Italian speakers for your wonderful talk and comments. So now I will give word to Professor Fang to give us the final conclusion remarks. Professor Fang, please. Thank you, Professor Luo. So I think today's meeting is very insightful. So I think this is also a fancy meeting because for patients and for the bacteria, they are actually constantly changing. And so I think COVID changed our patient and our society. So in the past, majority of the patients have like the infection of the adenovirus, the influenza, as well as the streptococcus pneumonia. However, after COVID-19, after the 3 years pandemic, we see a lot of the community-acquired pneumonia patients because we have so many different bacteria, and nowadays we see more resistant cases, and for clavicle pneumonia infection as well as the E. coli infection, and for streptococcus. Nowadays, for streptococcus pneumonia to MSS, as well as Staphylococcus aureus infection, as well as MRSA infection, and also for Staphylococcus aureus infection, it is highly virulent with quick progression. It is very tricky. So this is the new situation we're facing, and that's why we need to pay more attention to those patients. For community-acquired severe pneumonia, I think, for hospital-acquired pneumonia, it is important to cover resistant strains. And right now, we are hesitant to do combination. We hope that monotherapy is able to cover the possible pathogens. So nowadays we have the 5th generation cephalosporin, cephalosporin, to help with us. So with that, we are able to better treat those patients. So I think tonight is indeed a wonderful night, whether it's the case sharing or the special talks.
Thank you so much. It's been a rewarding meeting for all of us. So that's all from me. It's been a rewarding meeting for me. Thank you so much. And thank you, professors from Italy. Thank you all for your participation and a lot of information that you have shared with us. We really learned a lot from you. Wish you all the best. See you next time.
See you. Thank you.